So to continue on the topic of hepatitis, the pathophysiology. During an acute viral hepatitis infection, liver damage is mediated by the cytotoxic cytokines and natural killer cells from the body's immunity that cause lysis of infected hepatocytes. Inflammation can interrupt bile flow or cholestasis. After resolution of an acute infection, liver cells can regenerate, and if no complications occur, they should resume their normal appearance and function. A chronic viral hepatitis infection causes chronic inflammation and can cause fibrosis that over decades can progress to cirrhosis. The antigen-antibody complexes between the virus and its corresponding antibody may form circulating immune complexes in the early phase of hepatitis. The circulating immune complexes activate the complement system. The clinical manifestations of this activation are rash, angioedema, arthritis, fever, and malaise. Cryoglobulinemia, abnormal proteins found in the blood, glomerulonephritis, and vasculitis have also been found secondary to immune complex activation. The clinical manifestations of viral hepatitis can be classified as acute and chronic phases. A large number of patients with acute hepatitis have no symptoms. They're asymptomatic. As a result, infection during the acute phase may not be detected in all patients. Others may have intermittent or ongoing malaise, fatigue, myalgias, arthralgias, and hepatomegaly. The acute phase is a period of maximal infectivity. It lasts for 1 to 4 months. During the incubation period, the symptoms may include malaise, anorexia, weight loss, fatigue, nausea, occasional vomiting, and abdominal discomfort, usually in the right upper quadrant. The patient may find food repugnant, and if a smoker, may have distaste for cigarettes. Sense of smell is also decreased. Other symptoms may include headache, low-grade fever, arthralgias, and skin rashes. Physical examination may reveal hepatomegaly, lymphadenopathy, and sometimes splenomegaly. The acute phase may be icteric or jaundiced, or anecteric or no jaundice. Jaundice is a yellowish discoloration of body tissues resulting from an alteration in normal bilirubin metabolism or flow of bile into the hepatic or biliary duct systems. The urine may darken because of excess bilirubin being excreted by the kidneys. If conjugated bilirubin cannot flow out of the liver because of obstruction or inflammation of the bile ducts, the stools will be light or clay-colored stool. The pruritus, intense chronic itching sometimes accompanies jaundice. The pruritus occurs as a result of the accumulation of bile salts beneath the skin. The convalescent phase following the acute phase begins as jaundice disappears and lasts for weeks to months, with an average of 2 to 4 months. During this period, the patient's major complaint is malaise and easy fatigability. Hepatomegaly remains for several weeks, but splenomegaly subsides during this period. Recovery. Prior infection with HAV or HBV can provide immunity to that virus, which is homologous immunity. However, the patient can still be infected with another type of viral hepatitis, as well as different strains of hepatitis C virus. Most patients with acute hepatitis viral hepatitis recover completely with no complications. The mortality rate is higher among older adults and those with underlying debilitating illnesses, including chronic liver disease. Complications. Complications that can occur include acute liver failure, chronic hepatitis, cirrhosis of liver, and hepatocellular carcinoma. Almost all cases of acute hepatitis A resolve, although a small number of patients may have a viral relapse in the first 2 to 3 months after the infection. The disappearance of jaundice does not mean the patient has totally recovered. Some hepatitis B virus infections and the majority of HCV infections result in chronic, lifelong viral infection. Alterations in the patient's cellular immune response may be important in the development of the chronic HBsAg carrier state and the progression from acute to chronic HBV infection. These immune system alterations may explain why patients with chronic kidney disease who are undergoing dialysis when hepatitis B develops are more at risk for developing chronic infection. Persons with chronic kidney disease have a depressed cellular immune response. The risk for infection to become chronic is greater for HCV than for HBV. Many patients with chronic HCV infection will develop chronic liver disease, cirrhosis, and hepatocellular cancer. Risk factors for progression to cirrhosis include the male gender, alcohol consumption, and excess iron deposition in the liver. Elevated cholesterol or triglyceride levels, obesity, and diabetes mellitus are also risk factors for the progression of HCV infection to cirrhosis. Diagnostic studies. The only definitive way to distinguish between the various forms of viral hepatitis is by testing the patient's blood for the specific antigen or antibody. In viral hepatitis, many of the liver function tests showed significant abnormalities. Liver enzymes, namely AST, ALT, and alkaline phosphatase levels are all elevated. Serum proteins, namely gamma globulin level, is normal or increased. Albumin level is normal or decreased. Serum albumin and urinary bilirubin levels increase. Urinary urobilinogen level increases 2 to 5 days before the jaundice appears. Prothrombin time is prolonged. Viral genotype testing is done in patients undergoing drug therapy for HBV or HCV infection. Physical assessment may reveal hepatic tenderness, hepatomegaly, and splenomegaly, and the liver is palpable. Treatment or collaborative care. There is no specific treatment or therapy for acute viral hepatitis. Most patients can be managed at home. Emphasis is on measures to rest the body and assist the liver in regeneration. Adequate nutrition and rest seem to be the most beneficial for healing and liver cell regeneration. No special diet is required in the treatment of viral hepatitis. Emphasis is placed on a well-balanced diet that the patient can tolerate. During acute viral hepatitis, adequate calories are important because the patient usually loses weight. If the fat content is poorly tolerated because of decreased bile production, it should be reduced. Vitamin supplements, particularly B complex vitamins and vitamin K, are frequently used. If nausea, anorexia, and vomiting are severe, IV solutions of glucose or supplemental enteral nutrition therapy may be used. Fluid and electrolyte balance must be maintained. Rest reduces the metabolic demands on the liver and promotes cell regeneration. The degree of rest ordered depends on the severity of the symptoms, but alternating periods of activity and rest are usually adequate. Counseling should include importance of avoiding alcohol and drugs detoxified by the liver. Also, the patient should notify possible contacts for testing and prophylaxis if indicated. a liver biopsy is not indicated in acute hepatitis unless the diagnosis is in doubt. Patients who have a bleeding disorder may not be appropriate candidates for biopsy because of the risk of bleeding. In these patients, a transjugular biopsy may be an option. Drug therapy. There are no drug therapies for the treatment of acute hepatitis A infection. Treatment of acute hepatitis B is indicated only in patients with severe hepatitis and liver failure with interferon and nucleoside and nucleotide analogs. They work well with suppressing viral replication and prevent complication of HBV. Drug therapy for HC virus is directed at eradicating the virus and preventing HCV-related complications. Treatment with pegylated interferon within the first 12 to 24 weeks of infection has markedly reduced the development of chronic hepatitis C. Pegylated interferon is conjugating standard interferon with a polyethylene glycol, which delays elimination of the drug. Treatment of chronic hepatitis C is individualized and based on the genotype of the hepatitis C virus. Protease inhibitors are also given in conjunction with interferon. Protease is an enzyme that is essential for viral replication. The duration of treatment depends on the genotype and can be from 12 to 48 weeks. Supportive drug therapy includes antiemetics for nausea such as chlorperazine, promethazine, and ondansetron.